And first, all right, I'm glad we're recording this. I think this is going to be a great talk. So first and foremost, I'd love to have our super contributors introduce themselves, and briefly describe their role in training behavioral health consultant students. So,
sure.
Yeah.
Bridget, you want to start?
Sure. How's my audio?
I can hear you, Bridget.
It wasn't very convincing, Corey.
Well, it's kind of coming and going, but the hospital I'm in, we don't have very stable Wi-Fi, so I'm doing the best I can too.
Speaker things. Can anybody else maybe in the chat box tell me if their internet is faster, if it's coming in clear?
It's coming in clear for me.
Okay. So my name is Bridget Beachy, and I'm a clinical psychologist by trade, and was introduced to PCBH work in my graduate school, which is very rare, back in 2010, and changed everything over to primary care concentration, did a pre-doc, a post-doc with the one and only Kirk Strassel at Community Health Central Washington, co-founder of ACT, co-founder of FACT, and of PCBH in general. So feel really, 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 really grateful to be here and to do the work of a BHC. And so specifically, we train folks, we train pre-docs and post-docs. We also have a number of folks internationally who come and do rotations with us. A lot when Dr. Strassel was here. We have master's level students too that will come in and out. And quite frankly, we just have a lot of folks across the country who will just come and see how PCBH is in action. So just super pumped to be here.
Hi, I'm Meghan Fondow. I'm the Director of Behavioral Health at Access Community Health Centers in Madison, Wisconsin. And I'm a clinical psychologist as well by trade. We have many different trainees of different levels that have worked with us over the years. Currently have a postdoc program. And in terms of the question here on the screen, what initially attracted me to PCBH work? I got introduced actually during my postdoc year. I was a postdoc here at Access, trained under Naftali Serrano, who started our program here. I hadn't had a whole lot of exposure to primary care, but did a lot of training in health psychology in graduate school. My grad program did not have prac sites in primary care at that time. I think it was just starting to, the field was just starting to grow and explode at that point. So that was my exposures in my postdoc year. I obviously loved it and was very sure within a month or two of my postdoc that I wanted to stay. So I started making noise pretty quickly. Hey, looks like you might need some more help. He was the only psychologist here covering 2 sites at that time. So I put my pitch in early and luckily it worked out well. So that was my experience along the way. And again, we do have a current postdoc program. We've had practicum students from social work, from clinical psychology, counseling psychology. We actually had marriage and family therapy students at one point and have pulled from many in the Madison area, Milwaukee, and even Chicago students have come up. So it's been a lot of different numbers of students over the years, a few less right now in pandemic times, not as much space in clinic.
Yeah, and I will just say, Corey, that myself, many folks know my partner in crime, Dr. David Bauman. We kind of had to stalk some people's lives to make some of this happen. So in Missouri, we didn't even go to that we went to grad school just for it to be a general program. I had never heard of anything to do with primary care, psychology, or PCBH, BHC, integrated care, none of that. And in my second year in the program, our health psychology professor did work as a BHC at an FQHC in Springfield, Missouri. And so she started talking about what she did. And I'm like, well, that's what I want to do. So started looking up books online, stalking Patty Robinson and Kirk Strassel's life. And somehow by the grace of the heavens, matched at Health Point, which was headed up at that time by Jeff Reiter, who was trained directly by Patty Robinson and Kirk Strassel back in about 2000. And then he took on the program at Health Point. I didn't even know that. We were like during the interview quoting Jeff Reiter to Jeff Reiter, which is so embarrassing. so embarrassing now. And also quoting to Kirk during our postdoc interview, oh my gosh, it just seems like acceptance commitment therapy and PCBH just go so well together. And he's like, yeah, I created it that way. And I was like, oh my God, just kill me now. But made it through.
I mean, I appreciate those moments though, because those moments, like as silly as they are, they kind of ground us. And I think it really demonstrates our passion for this. You know, when we can come in and really speak to how wonderful the PCBH model is, how wonderful integrated care is, you know, and these different models that we operate from, I think one of the best parts about it is it's all really centered upon like good patient-centered care, you know. And so I really like this aspect though, that I think both of you all, you kind of had to do some searching out for this. And I think that's, you know, one of the really tough parts is as I spend more time in CFHA and as I talk to other students, there's a lot of people that are still having to search for this, which almost seems crazy to me, you know. But I was fortunate to come from a graduate certificate program that Stacey Obeid has been really having an instrumental role in. So I stayed in an extra year because I was just floored with it. And I was like, this is what I want. This is what I want to do, you know? And so it really moved me in some very powerful ways. And now I'm in a doc program to become a psychologist to, you know, continue on this journey, you know? And so one thing I do want to do is open the floor though to people as well who are, you know, on this call, and maybe they can share some of their experiences of how they found their way to PCBH, or maybe what their journey looked like. So I encourage anyone just to chime in, share. You can even use the chat box as well.
And Corey, full circle, Stacey and I went to the same graduate school. She was a year older, and my goodness, did she set our grad school on fire. She was the best student ever, and we all looked up to her. And I did my first ever poster ever because of Stacey mentoring me along. So huge shout out to Stacey Obeid. Full circle on this. And, you know, PCBH is 7 degrees of Kevin Bacon with Patty Robinson and Kirk Strassel, because Kirk and Neftali, he'll tell you those stories.
Yep. Oh, I know those stories.
It takes a village. It takes a village. It really does. Well, thank you for sharing that, Bridget. Let's see. So anyone, feel free to chime on in. I'd love to hear about, you know, your experience.
I can talk.
Please.
So my name is Fernanda Hernandez. I'm Mexican. I moved to the US to study social work. I'm studying at Bryn Mawr. My first to study social work. My first year I've been working with children all, you know, my life. And this is the first, like my first time in field. I was working in an elementary school. I have been very passionate about social justice, working in underserved neighborhoods. That's where I feel my work makes the most sense. And that's, I think, what brought me to BHC services, because I realized while working with the kids I was working at in this neighborhood that first I wanted to know more about the needs of family needs. I realized also that primary care setting is where people definitely have to go. They will go necessarily no matter what. They will not. I think it is a less stigmatizing setting to offer mental health services. At first, I was shocked for the brief work we were going to do, but also this fascinated me in terms of the work one can do when knowing it is short, like it is limited with the amount of like sessions you can have with patients. I'm interested in staying at this clinic. It's called Maria de los Santos. It's part of the Delaware Community Health. And yeah, I also wanted to be here because this is where my population of interest, Hispanic, Latinx people come to. And yeah, so that's what brought me here. I want to keep doing this, and I joined this conversation to learn more about it. and to feel less lonely. Yeah, so thank you.
That's amazing. Thank you,
Mhm.
Fernanda, for sharing. Wow. I mean, you said that so well. I don't know, Megan, when she was talking, like how many things she was hitting, like go where the people go,
Decrease stigma.
decrease stigma.
Yep. And the breadth of what we're able to cover, right? In primary care, we can do a lot.
You're not alone.
Nope,
Folks are
not at
doing
all.
this work.
Welcome.
Thank you. Thank you. Also, in terms of prevention, there's so much work we can do here.
Yes.
Of suicide,
Agreed.
for example. Anyway, thank you.
Yeah, thank you, Fernanda, for sharing that. I really, I think that there's a real calling for this kind of work. I really do. Like, there's something that speaks to us about it. I also really like the flexibility of this model in that all the unique needs we can meet. So I really appreciate your perspective on that and can't agree more. I like the fact that we have these kind of calls because we are a community,
Yeah.
and so I really think it's important to, support, mentor, bolster each other up, but also show that we're just here for each other when we need it. So thank you. Bridget, I see you're on fire with the chat. I love it. As far as putting the visit caps in place, I mean, I can't agree more. Like it's so hard if you have just such a limited number of visits, even though we can encourage such dramatic change. It's really tough if we're like, well, I can only see you 4 more times, or I can only see you 3 more times, because then it's like it almost puts a rush on something that can work fast. But as we know, so many things happen out in the world. It's impossible to account for all that.
And now I'm going to be completely shameless with word dropping, name dropping, talking with like I said, the huge honor and the world came together. And I can't believe that had the opportunity to work with these phenomenal folks like Stacy and Jeff and Patty and Kirk, who created maybe a strong word, put together, the 2007 behavioral health consultation and the updated version with Robinson and Ryder. If you talk to them directly, they never, ever, ever intended to have visit caps. It's not, that's just one of those myths that happens. Now, I say all this, but I understand that there's different contexts. So I'm not saying it can never happen. There could be some good reasons and function for it. But in general, the creation of primary care was supposed to mirror primary care. There are not visit caps in family medicine and primary care. So again, you're going to have to look at your specific context, your specific setting. There might be very good reasons for it, but that is not inherent in the PCBH model. That's we should definitely make another video about myths of PCBH. That wasn't intended. And we've run our metrics for 8 years now. The average number of visits per patient across our entire system is like 2.7. And we do not do visit caps, and the mode number of visits is 1, just like every other place in the country that does private practice or any type of psychotherapeutic. The mode number has always been 1. And so you don't need the visit caps for it to work out that way. So I'm sorry I went off on that. It's just, it shuts things down, and it's the opposite of what we're trying to do with social justice. So it gets me a little bit riled up.
Yeah, no, I appreciate the passion. I really do. I get riled up too. So normally that doesn't always get received well. But I really, I think that speaks a lot to not just our passion for the work, but the importance of what we really focus on in the long term with this. And, the value that we see in this and the work we do. I do notice in the chat, there was a comment from Rosemary about how she entered grad school for clinical health psych as to be a generalist and really didn't find out about PCBH till her 3rd year. And so from there, she just took off with it, went to an internship at an FQHC, and is currently in a postdoc position creating a PCBH program at a county hospital system. So Rosemary, it sounds like you're doing some wonderful work there. And it looks like she's probably stalked a few people on this call. But yeah, I think that's a really wonderful point, is, addressing things like those myths within the model. Megan, I'm curious, based on your experience, what are some of the things you've run into along the way with that?
I think that one of the things, especially early on when we were first rolling our program out here, nobody else in our local community was doing PCBH work. So a large part of it was helping both patients, also our own staff, and then other organizations to understand what we were doing, because it didn't fit in any boxes that people had, right? And so we had to basically help to teach those boxes, create a new box to understand what we're doing, and to help folks to understand all that we can do and what the limitations are, that we're not trying to replace specialty mental health. That was probably the biggest thing that I had to talk to agencies about a lot my first couple of years working here, that we were not trying to replace specialty mental health. We actually really wanted to partner with specialty mental health, because all parts of the system are needed to get everybody the care that they need. So that was definitely one piece. I don't know that that's such a myth anymore. I think that the systems have been around long enough that people have seen that they can coexist quite well together, which is lovely to see, because it's very much mirroring, right, what happens in medical care. People go to the primary care and then they get referred to cardiology if they need to see cardiology, and there's no expectation that primary care is going to take over cardiology. When I've used that analogy with doctors and other folks, they're always like, yeah, that would be silly. Why would we do that? So yes, so it's the same. We're also not trying to take over for psychiatrists or other psychotherapy in the community. We want to just partner together to create the right care for everyone.
Yeah. I mean, I think that's one of the things I really appreciate about that perspective, but also what I love about this model is bringing everyone together,
Mm-hmm.
And really trying to work collectively. And, I definitely, I hear a lot more about PCBH, integrated behavioral health, than maybe I did 2-3 years ago, I think, but there's still a lot of mysticism behind it. And there's still a lot of people that like, well, you just kind of do this thing, and it's like, it involves the doctors. And it's interesting because I find myself kind of stepping in that educator role sometimes with people that are probably a little bit further up the totem pole than me. So I have to be respectful, but I think it's really important, just because, I mean, that's part of our role, is being educators, and so sometimes we need to take some ownership of what we do, but we also need to explain to people, this is how we can help you. Like, this is how I can make your life easier.
Mm-hmm.
So
yeah, that education piece is a big deal. And I think that it's definitely something that when you start this work, you learn pretty quickly how to explain what you do, right? Not only to patients, but to other professionals. And it's something that I still do to this day when I talk to somebody from another agency, when we're collaborating for a patient, to step back and say, oh, and do you know my team already? Can I share what we do? Just to give people that context right away so that it's clear.
Yeah, I mean, and that's nice when we can kind of get all those stars aligned and basically be able to create those structures for what we want. I do notice in the chat as well, there's a comment from Elaine, who was working in a small rural tribal clinic, and they had a BHC, and she really liked what she saw, and basically, I guess, received some extra training in that, and her clinic ended up making a position for that. So Elaine, I think that's wonderful. It's kind of, when clinics and systems see the benefit of this, I mean, it's amazing when they're like, we need this, we need more of this, we need more of you here. So I think that's a wonderful thing to have. Let's see. Collaboration is very important part of holistic care. Collaboration is like the bedrock, because the thing is, we just can't do it alone. Like, if that's what we try to do, we'd be in specialty mental health, and this is why we have these huge wait lists. So, I think that's a really important factor of it. So, well, I'm excited to the start of this so far. I think we've really touched on some really great big things here. So I think the next question gets a little more at some of the, probably one of the many reasons people are tuning in today. So let me go ahead, click over to that. All right, so I think these are two pretty big questions, but I think that they really address probably what a lot of people that are students who are currently working as a BHC or in a BHC role, or even those who maybe are in postdoc or even just starting a career. These are probably some really big things. So, all right, Meghan, you've been nominated by Bridget to go first.
Thanks, Bridget. Challenges that I initially encountered. That's a great question. So full disclosure, that was about 15 years ago for me. So I'm going to roll my memory back a little bit. I think one of the biggest things was figuring out, I understood on an intuitive level what we were trying to do. It made total sense to me that we're trying to provide care to people in the moment when they're asking for it, regardless of, in my setting, regardless of ability to pay, because I'm in an FQHC, trying to help those who otherwise wouldn't have access to care, maybe the first contact, all of that was like, yep, that all makes sense to me. trying to verbalize it, to explain it, I think that was hard. And that took me a little while to come up with a spiel, an explanation that felt comfortable to me, that didn't cause people's eyes to glaze over, and that I didn't go down rabbit holes when I was getting excited about it along the way. So practice was a big part of that. And practicing the intro spiel is something that I still have our current trainees of whatever level. I have them practice it quite a lot. They practice it with each other, they practice it with staff, and then they eventually get to practice it on patients and other agencies in the community. So I think that that was a big part of it. And then also listening to feedback from patients. My spiel has shifted over the years, right? As I get feedback from people, or if I've had repeated questions, then I say things a little bit differently, right? To make sure that I'm continuing to address what are current concerns, or maybe something that I haven't been explaining as clearly as I could have. So it's kind of a constant process of back and forth. So a lot of I mentioned building a box before. When you're building your kind of your mental model of what this work is trying to accomplish, I think that that is a process that you do initially, but it continues to get refined, right? As you do the work for a longer period of time and get to see all that we're able to accomplish in primary care, and how much good we can do. Bridget.
Yeah, I love that, Megan. I could not agree with you more. And CFHA, as well as my partner in crime, Dr. Bauman, has a bunch of videos on how to do an introduction. Some of them are as short as 1 minute and 10 seconds. And then I think he's got a 2-minute video that explains the importance of an introduction. So I'm so glad, Megan, that you're doing that in your training, although I'm not surprised at all. Access has a really awesome regimented program. Yeah, I mean, there's endless challenges as a student. I mean, I was jotting down a few ideas, and I'm going to piggyback on Megan here that one of the best things was building that mental model. So in 2018, when the special edition for PCBH came out and really kind of cemented Gather as being kind of the foundation of PCBH, that was very, very helpful. It was already in the 2016 edition, Patty and Jeff's 2016 edition, but it kind of made it like, okay, this is what PCBH is. And so have Gather tattooed into your skull. So that's, if somebody wants to put into the chat box, you can, to be a generalist, to be accessible, to be team-based, have high productivity, to be an educator, we talked on that already, and to be a routine part of services. The other thing that I've etched into my skull is the 4 C's of primary care, being the first contact, coordination of care, comprehensive care, and comprehensive coordination, first contact. Oh my God, I said tattooed into the brain and now I'm blanking on it. It'll come back. Coordination, that's gonna bother me. Comprehension, coordination, first contact. Continuity, my goodness, the bedrock of what we're doing, continuity. And then what a family doc does with the cadence of primary care, you can glean a lot from. Well, when do I have the patients come back? What can I do in a shorter visit? How can I have continuity and build that up over time? You can glean that and kind of use that as a mental model as well, is looking to your family medicine doctors, seeing how they do their practice. The contextual interview was a game changer for me when Kirk kind of really taught me how to do a love, work, play assessment, game changer clinically for what to do in the room. He also told me reps, more reps, and get some more reps. Don't be too hard on yourself in the beginning. The more reps you get, the more comfortable you'll get. And the last thing is less is more. Get that also tattooed in your brain.
Those are great, Bridget. I have one more that I was going to add on to piggyback onto yours. I really like the reps part. I think that that's a huge part of the learning of the work. Part of that also is the repetition to learn to develop your internal gauge for your timeline for how long you're in the room, right? To start to develop a internal radar of like, okay, I've been in the room 15, 20 minutes. I'm edging into where I want to start to think about wrapping up. That's something that I know was something that took a little bit of time to learn for myself, but pretty quickly felt very natural. And then I think for other trainees along the way is something that I encourage them to do too. So taking a look at the clock before you go in the room, right? and then taking a look as you come out to kind of see how did you do, and then starting to develop that radar for timing makes your day much more efficient. And it starts to be more adhering to what we're trying to do in the model.
Yeah, I mean, I'm blown away because really all of that, it's so essential. I mean, as most of us know, we got to set ground rules with things. And so by setting the tone of our visits and really developing that good elevator pitch is like, okay, this is what I do here. This is how I'm different from traditional mental health. This is how long you're going to see me for. And really, these are the services I offer. It's just so valuable because then it's like, okay, we can, I guess a better way to look at it, but this is what's coming to mind, is we can get down to business quicker, and we can always address any immediate concerns. We can always explain that we're not the same as traditional mental health, quote unquote. However, this is what we can offer, and most of us also are trained traditionally as psychologists, social workers, counselors, licensed marriage and family therapists, whatever that may be, so it also demonstrates our knowledge, and that it's like we are somebody who knows what we're talking about. I think the other part of it that I really like that you were also bringing up, Bridget, is burning a lot of this into our mind, but also having a little self-compassion when we hit some snags, or we maybe have a tough patient, or maybe we forget to do something, because I mean, let's be honest, we're human, so I think that is a really important part of it. And I know for like myself, diffusion is a big part of that for me too, to help get some space from those things. So yeah, I think those are awesome. And I mean, Bridget's sharing all kinds of just little nuggets down in the chat. So, I would encourage people, if you're not familiar with the GATHER acronym, wonderful publications on it, wonderful materials through and through, and it really gives you a great breakdown of the PCBH model. I do want to open the floor as well to maybe some challenges that others have experienced on this call. I know for me, one of my biggest challenges was sometimes selling providers on the PCBH model, especially some that are not as accommodating, or that sort of thing. But I'm curious as well, what are some of the challenges that you all have run into? And we can either go through the chat or just feel free to shout out and let us know.
And Corey, just because there's an awesome comment from Rosemary in the chat while we're looking at that. The other thing to remember is patients don't know what you're supposed to do or not do. So if you forget something, it's okay. They don't know what you're supposed to be doing. Now, that's not an excuse to go and be ill prepared or something. Yeah. But if you forget to say something in your intro, like, it's gonna be all right. And patients read your heart. So if they know that you're in there and you're going to talk about what you can help them with, but you forgot to add that you're going to chart into the EHR and you remember it later, that's okay. Corey, I love that diffusion and that self-compassion piece that you brought up.
Yeah. Well, and I really appreciate what you just said, Bridget, as well, because I think we forget that. I mean, and I'm just going to say, I know we forget that. I know we forget that. And so I think that's right. Having that self-compassion diffusion is important, but I really appreciate that point. And I mean, I wish that's kind of one of those bold things that are just out there, but I know I'm going to tattoo that in my mind right now too, using our earlier analogy. But I'll first chime in on this excellent comment in the chat, and then we'll jump into some other challenges people have encountered. So this looks like Rosemary, one of the challenges she dealt with was having maybe some supervisors not trained in PCBH, and that's actually something I've experienced as well. And it's hard because, yeah, it's a lot of reading, it's a lot of education, and I think one of the points that she really brings out is getting connected with community, especially like CFHA, is really helpful because we have such wonderful, super contributors like we do today. We have such wonderful networks. We just have so many fantastic content experts, and people that have been through this process. So I really appreciate you adding that, Rosemary. And yes, this will be recorded as well. So, we will have this up for you all later on. But what are some other challenges that some of the people on the call here have encountered?
I would also say, hi, everyone. My name is Brittany.
Welcome.
Have my master's in marriage and family therapy. I'm doing pre-doctoral work at the Chicago Center of Family Health here. But I know I started out, my first experience in integrated care PCBH model was working at FQHC in Southern California. And prior to that, I traditionally work in more traditional therapeutic settings with like 50-minute session times. And then the culture is different. You're around other therapists all day. And so I think one of the biggest challenges for me initially was like adjusting to the medical culture, you know, and some of the assumptions that I make just from being a patient in primary care, like the hierarchy that's there, sometimes the power differentials that can be there with working with providers. And then now being a provider in that setting, like having to overcome all of those assumptions and biases and seeing myself as like a part of the healthcare team and seeing myself as like being able to work collaboratively. Someone had put in the chat to like look to family docs with your practice management, and I definitely had to do that, you know. And so it's kind of all of those pieces that I really had to make adjustments to at the beginning.
Thank you. Those are such great points. I really appreciate that, because the culture of primary care is, of course, a huge, a huge piece of the puzzle. And I've had a lot of trainees over the years that have come through, and some will actually start to work in primary care and say, oh, this is great, this is what I want to do. And others are like, you know what, I'm not sure this is actually a good fit for me, as their eyes get bigger and bigger with the amount of chaos going on, right? And that's okay, right? That's okay. That's why this is such there's different places that are going to be a good fit for different people. And I think that's one of the things that I encourage students to really think about, is what feels like a good fit for you, what energizes you, right? What's going to get you to feel like you're able to feel replenished, to be able to take care of yourself, because wherever you practice, you need to be able to take care of yourself to be able to sustain a career as a helping professional. So that's a great point, Brittany. I appreciate it.
Yeah, it's almost like we have a little bit of BHCs have imposter syndrome on steroids to a certain degree, because you're trained in one thing, so you kind of already have that imposter syndrome and, you know, being new in that, and then to go into shift into a completely different setting with a whole different set of rules. That's like, and then like you added, Brittany, about being in the medical culture and what we know from, you know, minoritized folk, women, you know, there's a certain hierarchy. So then that kind of is like another factor all at play when, and I feel like I tell our interns, like, I can't say it enough, like, it's okay if you don't believe in like that, you to know your value, but I just need you to know that you matter, and the value you're bringing to our organization is off the charts. It's okay if you don't feel that yet, you know, the ACT piece of like, you might not actually believe that yet, but I'm not going to stop saying it, and we'll roll with it, because we have a huge role to play. So Brittany, I'm so excited that you're recognizing the value that you can add to your organization. Were there any tips that you have for, like, I don't know, what you did to kind of get your mind into that space that you can contribute and how important you are? And again, and not like an egotistical way, of course.
That's a great question. I think it came with like having really meaningful conversations with some of the attendings like that were there, and they really validating, like, we need you here, we want you here. Having behavioral health providers here really helped to support the patients that we see. And so I got on board with this idea of like, we're a team, right? And so being open to having dialogue with the providers within the department was really helpful and continues to be helpful to me as I have moved through different sites. So.
Yeah, I mean, that's wonderful, Brittany. Thank you for sharing that. I think it's sometimes we lose track of that, you know, is really what we're bringing to the table. And I think our change isn't just sometimes an immediate change. Sometimes it is, but it's not always an immediate change we're going to see in the office. And so, you know, we want what we're doing to generalize to the world out there. So I think that can be the hardest thing until we get a follow-up visit or we check in with that person and we see how wonderful they're doing, you know, and then it's like, wow, it's like, okay, like this does have an impact. It's like, sometimes I have to sell myself on it a little more initially. So I think that's a really great point that was brought up earlier by Bridget as well. So yeah, I love this so far. So I know we got a lot of people on the call, and so I want to open up because I'm liable to believe that probably other people may have had some challenges as well. You know, probably at least one or two. So, please feel free to chime in. You can use the chat box. You can just unmute yourself, but we'd love to hear about it. And maybe just a, quick talk about how you address this, or maybe some ways you overcame these barriers.
Yeah, I am currently, I'm a student. My name is Sierra. I go to Xavier University, and we are actually, I'm grateful because we have like an emphasis on the PCBH model. So I am at a practicum site right now working as a BHC, and I'm in like a semi-rural area, and we don't really have a ton of connection to other mental health providers. And I find myself just constantly like struggling with, I want to help this person so bad. And I know they need more consistent, like a higher dosage of care. And I just feel stuck. Like I want to help them so much. And like I want to be accessible. And I don't have any like solutions to that challenge yet. So any feedback would be very appreciative and beneficial.
Yeah, Sierra, if you can go back to CFHA's extended learning opportunities, did you have a chance, Sierra, I can see you on the video, to access Dr. Kirk Strassel's talk on complexity?
I don't think so.
Yeah, I think it was something like working with complex patients in PCBH, and it was at the primary care behavioral health ELO from this past year, 2021.
Okay.
I can just say now that nobody says things more eloquent when it comes to that topic than he does. So I'm like scared to even answer, because I know that whatever is in my brain is not going to come out. And I'll go back to muting myself because I want to hear what others think, because I do have some thoughts on it, but I'm gonna mute myself.
Well, I'm happy to chime in with my thoughts. I haven't actually seen that talk yet, Bridget, so thank you for reminding me of it. It's on my list of the ELOs that I wasn't able to get to all of them this year. I think that this comes up a lot for lots of different settings and for lots of different reasons. I think it also comes up for trainees of different types because of getting used to what we do in primary care, and like, where is that line between when do we refer out, right, to specialty mental health, especially when we may be familiar with what we can do in specialty mental health, right, because we may have had some training in that area, so we know what that system can also do. It's a lot more complicated of a question, I think, because access to care is for sure a huge barrier, no doubt. Patient's choice is also a piece of the puzzle. Sometimes patients don't necessarily want to go someplace else. They're very comfortable coming to what's familiar and it's easy to access and they like you, which is always nice to hear. And I think that it's also true that we can sometimes sell ourselves a little bit short, right, with what we're able to do in primary care, because we can actually do quite a lot. We can't reproduce some more specialty care, obviously, nor are we trying to. There's a lot of space between those two, right? So one of the things that I've always thought about, which I think probably came from Jeff Ryder back in the day, was do something now, right? Like, yeah, it's great to be talking about potentially what specialty therapy could do for this person down the road, but what else can we do today, right? That alone of talking about a referral is a piece, but is there some other skill? Is there some other intervention? Is there something else we can offer now in this moment that could still be beneficial, while also holding the space for the fact that there's going to be a lot more work, right, that we could do or that we may want to do with this patient down the road. I think that can be a hard thing to hold on to when you start to see, oh, I'm starting to get this. I'm starting to understand like the whole scope of what we could do to help this person to do better. Like, yay! And I can't do it all in one day. Like, we can do a lot in one day, but we can't necessarily do it all in one day, right? And so that idea of stepwise care becomes part of the plan too, right? What can we do today? What could we plan for another snippet for next time? This stuff is powerful. I've had patients come back that I talked to 5-10 years ago, and they're like, you know what? That was really helpful. And I never came back and told you, and I'm sorry, but I'm telling you now, thank you. And so I've learned that way, and also through hearing feedback in other ways, that there's a bigger impact than we might realize. So those are my thoughts. I'm starting to drift. I'll let someone else jump in.
That was very eloquent, Megan. There's something that stuck out in my head that just recently reading about managing chronic medical conditions in the medical setting. And it was, I believe it was somewhere in Up to Date. And they basically said, look, we as clinicians, again, they're talking more to the medical culture, but I consider ourselves part of that. We as clinicians need to manage and balance between what the demands are of the chronic condition and the person's, what their quality of life and what those demands are on their time. Less is more. People can only do so much. So these doses, these snippets, these things that Meghan is talking about, this idea that like, oh, well, they're going to go get more. After doing PCBH work now for 9 years, I can't even believe what we're able to get done and how many assumptions I need to challenge about what is better. And so I would recommend, as much as possible, less is more. One or two, meeting the patient where they're at, one, maybe two SMART goals that are highly linked to a person's values, their agenda, and to a certain extent, trust it. I'm in Yakima, Washington. It's rural. Our specialty mental health system is so inundated that they refer patients back to us. We have an opposite system where they're saying, because of how awesome our access is, because of course we do things differently, really good access, there are months upon months upon months, and there's nowhere else to go for most of these folks unless they have private insurance, blah, blah, blah. So I've had to get real comfortable with there ain't other options. So I get to know the person based on their love, their work, and their play. And on a dial, we move a dial one level. I mean, and that's, and you, what else can you do? And most of the time when you let yourself off the hook, so you're not carrying that anxiety into the room about what the patient needs to be doing, you let yourself off the hook and you honor that patient autonomy, you meet them where they are, people actually do get better. And you know what, sometimes they never get better, but at least you honored them with your full being, and you help the medical system honor them with their full being. I actually just recently had another patient who passed away, and myself and the physician, we've been managing this person for 5 years, and I don't think she made one health behavior change in 5 years. I swear to goodness, we never got it, but we honored her. We knew her inside and out. So when we found out she passed away, we had a good cry, and I don't have any regrets. And, you know, folks have autonomy. I'm curious to see how other people handle just that psychological heaviness that comes with wanting to do everything, and knowing that if folks would follow the regimen that we have, like the benefits that they could have, and then sitting when time and time again, sometimes there's no change. So, I mean, oftentimes there are, but sometimes there isn't. I'm curious, like how do you guys sit with that?
I feel like, hi, Beth Owen here in San Antonio. I feel like sometimes the intervention is letting the patient know that they have a choice and that they do have autonomy, and kind of fostering their self-efficacy. So they, you know, we could give them the options and they could still say, no, thank you. And I still feel like that could be successful because they are feeling like they have the power to choose. And it's not like, well, this provider's coming in and saying, do this, so I'm just gonna say, fine, I'll acquiesce, I'll do that. If somebody tells me no, I actually am like, okay, even though I want you to do these health behaviors, like I feel like they can actually have a conversation with me, and I feel encouraged by that because it means that they feel like they have some ownership in their care. And so I think that is how I normally, when I see people kind of make those choices, I'm like, it means that they're taking ownership and they actually feel like they can influence their care. So I'm like, great, that's not an option right now. If it ever becomes an option in the future, you know, I'm here and we can kind of keep going. So that's how I normally approach it, is like self-efficacy is showing up, even if it's not the way that I would choose, that's their choice, and we can kind of go from there.
That's lovely. I really appreciate the way you phrase that. Thank you. I also firmly believe in patient choice as well, and trying to find ways to encourage that. Goes along, of course, with trauma-informed care as well, to try to help people to understand what choices they have, what options they have, and not doing something is a choice, right? And that's okay. If that's what someone is choosing to do, that's okay. I think that can be hard to hold as attention when you can see the progress they could make. That's not our choice, right? That's their choice to make for themselves. There's probably reasons why they aren't wanting to do so, right? Which could also be something to potentially talk about and explore.
Kirk did a really good job during my postdoc of shadowing me and giving feedback. I'm just like, you're over here trying to push your agenda. What do you even know about this person? And I'm like, yeah, that's true. And so that's always stuck in my head, that if in doubt, well, first of all, we're always getting to know somebody with the Love Work Play interview. I mean, that's why we do it. But if you're kind of stuck and you're over there trying to push all these things that need to happen, it's a really good reframe. It's like, I just need to know this person and filter for their values, filter for strength-based, anywhere that you can kind of like leech onto. It's actually really fun to see what can you find to positively reinforce. It's so moving to do that, especially if we're not making progress on like a treatment plan. I know we moved a little bit away from that topic about what patients need and if there's not specialty options, but I can't help but think of that we can do actually more harm in some cases by always assuming that folks need more, or trying to push them to do more. And I'm not saying that you are or anything, like I'm just saying in general, us as a healthcare field, we have to think about the consequences of that too.
Yeah, and I just want to say, Beth, thank you for sharing that. I agree. I echo Megan's sentiment. That was really well said. And I think Bridget, one of the hardest things to sit with sometimes is we're taught, I can at least think of some of my experience, that people come to us, we're the experts. They come to us because of this problem and we're here to fix this problem. The hard part with that is I would say that's more of a biomedical perspective versus, we're trying to be more within that biopsychosocial realm, and in a lot of ways that's new territory. I think for a lot of us, we're not used to thinking that way. And so even sometimes we have a hard way communicating it. And so I think honoring autonomy, I think, is one of the most significant things that we can do, like hands down, because a lot of other providers aren't a fan of doing that. I mean, I can think of a lot of times where I've been with medical providers, or I've had a medical provider come up to me and say, hey, I need you to go tell this person to do this. And I'm like, yeah, that's going to work about as well as it just worked for you if I'm going to do that. I mean, even now, like I'm in an inpatient rehab hospital right now, and we have children we work with severe burns, and it's a tough situation sometimes. But one of the things we have to do our best with is honoring autonomy. Now, I'm going to go in and talk to this person, and we're going to see what we can do, and give them some sense of control, give them some sense of agency, because this is their life. I don't want to just be another person who's just telling them what to do. They already deal with that enough. So I really appreciate that. And I think that's one of the greatest gifts that sometimes we can offer in those moments, and then I think it was mentioned earlier about just demonstrating as well that we care, and, just that power of rapport and how important that really is. So yeah, I think this is phenomenal. And I was looking at Katina's post as well. Yeah, and so I think sometimes people do come to us for advice, as far as what to do. And I think we have to just be careful in those moments, because we're not living those people's lives as well. When they walk out of here, their care comes back on them, and so we have to, I think, just be careful to operate within that framework. But I like the aspect of at least informing, sharing, because I think one of the things that's told to me is a no today does not mean a no tomorrow, and so I think that's something that one of those things I've tattooed into the back of my mind, even when I have somebody who's maybe yelling at me or screaming at me. So yeah, the wonderful things we deal with this. But before we move on, because we have about 7 minutes left, we probably have one more time. We have time for one more maybe challenge or something that's come up, and then we'll finish up with one more slide. So if anyone has anything else they want to bring up, any challenges, that would be great. All right, well, let's see. Yeah, well, thank you, Anna. I mean, it's great to have everyone here. And I mean, I think that's what I love about these conversations, is that it gives people a really great chance to hear the experiences from others and see they're not alone in some of these struggles, and maybe learning some hard lessons along the way. So I really appreciate that. All right. So what we'll do is we'll go to the last slide. Click on this. And so this is kind of, I know this is a big one to end on, but I think it's really important as far as advice for students that are interested in a career in integrated behavioral health, or any tips or nuggets of wisdom that y'all have to share. They'd be great. That would be greatly appreciated.
I have one. Is it okay if I start, Bridget? I have one that I talk about with my postdocs all the time, all of my students, but postdocs in particular, because they're the ones heading off into independent land, right? Once they're done with postdoc. One of the biggest things I really encourage people to think about, well, there's two, but the first one is how to weave in self-care, right? How are you going to take care of yourself, to sustain yourself, and to be able to keep your enthusiasm and passion for the work alive as you work in this area over the years to come, right? We know that the work can be intense. We know that the work can be immensely satisfying, but heavy at times. And so what are you going to be doing for taking care of yourself along the way? It's a big transition, moving away from being on an academic calendar, right, to moving into a job, especially if you're going into an FHC where they're only potentially closed a few days a year. Otherwise, they're open all the time. So you really have to work to develop your own cadence for what do you need for some time off? What do you need for taking care of yourself, even at work during the day, all of that. So that's one we talk about throughout the year, but it's a big one that I encourage people to think about. That's probably the biggest. The second is also continuing to develop your own style, right? Giving yourself your permission to find your voice as a professional, as a BHC, hopefully, or whatever it may be that you're doing. What is that going to look like for you? I know for myself, that was on a personal level, one of my first supervisors in grad school told me that I smiled too much when I was talking with patients, to which I was like, that's weird. I don't know what to do with that. And I think you're wrong. And that's weird. So I'm going to keep smiling, and I still use humor with patients. That's part of my style. That's part of what I do. And I feel like that works. And I've had enough feedback at this point to feel confident that that is okay. So being able to develop your own voice and your own style, I think, is the other part of it too.
Amazing, Megan, and I'm glad that you didn't take that. It's always important to look at feedback, of course, and yeah, smiling too much. Okay. And I'm sure you were doing it appropriately. It's not like they were like, oh, my husband died, and you're like, yay. Like, I'm
yeah,
sure,
right.
Yeah.
Exactly. I hope not, but yes.
I would, yeah, I could trust that wouldn't happen. I don't really have something that much more than what I put into the chat earlier about the 4 C's, gather, looking to your physicians as practice management, doing the contextual interview, getting reps, and less is more. But I will say with the contextual interview, no matter how much time I have, I don't care if it's 7 minutes, if it's 11 minutes, 32 minutes, sometimes you don't know. Well, actually, I never really know what's going to happen as far as time-wise. It depends on the visit. That's another thing that Kirk would tell me. The visit takes as long as the visit takes. The contextual interview is etched into my brain. So I never start with the presenting problem. I know that that's contradictory to what a lot of us are trained on. If you have, and to Megan's point, if that's your style and it works for you, please don't change it. But for me and my recommendations, I would start with knowing the person's living situation, their relationship, their family, their friends, their income, and what they do for fun or hobbies, interest, or passion. The devil is in the details. You will save time up front. If you start with the problem, in many cases, you never get away from the problem and you never learn about the person. Whereas if you start with the living situation, the relationship, the family, the friends, the income, and what they do for fun or have a passion for, you're going to learn about them, and they're going to tell you in their own words what the issues are. Now, once again, like Megan had said, if whatever you're doing is working for you, then that's fine. But if you're looking to, like, I'm trying to go to the next level, or I want to switch something up, or this isn't working for me, That would be my biggest piece of advice, is start with that living situation, relationship, family, friends, income, and what they do for a passion, because everything that you're going to generate as an intervention should be directly from what your patient is telling you. You're going to have all of your evidence-based, evidence-informed, and you're going to filter it through the prism of their life. And whatever, and if you do this, what's waiting for you is most of the time this beautiful opportunity for a SMART goal that can be deeply linked to their core values.
Well, gosh, I really do think both of what you said, Megan and Bridget, I mean, I think those are more of those great pieces of advice that we have to do our best to kind of tattoo into the back of our mind, and I mean, Megan, as far as being ourselves, being authentic and genuine in the interaction, but also Bridget focusing on the values, the contextual factors, really what makes life worth living for a lot of these patients is so powerful. So as we're wrapping up, we got about a minute left. I want to thank you both today. This has been such a wonderful, wonderful talk. I think that maybe something we can explore in the future is maybe a part 2 to this, because I think that for many of the people on the call, and myself, I really think that this insight and this wisdom it's so valuable. And what's great is that it's something we can now carry with us, and we can also help those as well who are on their journey too. So thank you both for that.
Yeah, just honored to be here. It's been on my values is to connect more with students. I feel like sometimes it's getting, not that other work isn't important, but getting folks so far down the line, it's like, my goodness, we got to start sooner so you don't have to learn a bunch of stuff and then unlearn and then relearn. Like, that's crazy talk. Like, so I feel like the universe maybe heard that. I wanted to get more connected with students. So thank you, CFHA and Corey and everybody for you just allowing me to talk with you all.
Agreed. Thank you guys for the organization and for everybody for attending today.
Yeah, well, thank you both. And thank you again to everyone who attended. I hope you can take some meaningful things away from today's talk. Thank you all.
Thank
Take
you,
care.
Megan, and
Thanks.
Bridget, and Corey.